there's a little bit of a dark mood out there about the state of healthcare, right? You're feeling it. About costs too much, doesn't deliver quality or safety, and certainly for patients, it's not delivering on what it promised. But we're here to tell a little bit of a different story of hope and of change. And it's the recognition that there are three trends that are maybe unrecognized. The quiet revolution. Things that are happening out there maybe a little bit under the surface. That when we see them all come together, are going to completely take us by surprise in a good way. It's how patients are cared for, how care is paid for, and how people take care of their own health. So you may ask,
I would want to know, Farzad, how is the role of government in this set of forces that you've outlined? It's a question that we've grappled with, and the president answered in September of 2009 when he unveiled our strategy for American innovation, articulating the role of government in catalyzing breakthroughs in national priorities like healthcare delivery transformation. That strategy has three basic principles. The first, that our nation's at its best when we invest in the building blocks of innovation. You might think of that as infrastructure. Traditionally, we would think of that as roadways, railways, and runways. But increasingly, it means digital infrastructure. Secondly, the president said that we need the right market incentives, conditions that will spur those breakthroughs coming to market. What are the right rules of the road, if you will, that will ensure that we achieve the objective, those breakthroughs that Farzad had just alluded to in terms of the trends? And third, certainly not least, the president articulated a vision of bottom-up change, the theory of open innovation, that if we can tap into the expertise of the American people in pockets big and small in every corner of the United States, we might galvanize new ideas that sit on top of that infrastructure and are incentivized with the rules of the road to come to market and to deliver on the change that is so desperately needed in the healthcare system.
So government does innovation? No. The innovation comes from out there, right? Government sets the infrastructure, the rules of the road, and the conditions for innovation, but ultimately healthcare is going to be changed by the 5,000 hospitals, the 600,000 doctors, the 3.1 million nurses, and the 300 million people in this country. That's what's going to change healthcare. Let's visit one of them. This is Dr. Gustin Ho. I visited him in San Francisco a couple weeks ago. Small doc practice. Him and his wife is the practice manager. 3 rooms, exam rooms, 10-minute visits. Bam, bam, bam. 10 minutes, 10 minutes, 10 minutes, 10 minutes, 10 minutes, 10 minutes, all day long. That's his life. 10-minute fee-for-service. Fee-for-service means you see a patient, you get paid. That's what you get paid for. You get paid for seeing a patient. 4 elements of history of pleasant illness, 3 of review of systems, 2 of physical exam. That justifies a payment. You do a good job, you do a bad job, you get paid the same. You help someone quit smoking, you take more time, you get paid the same. That's fee-for-service. That's his life for the past 20 years. 3 years ago...
Nodding heads over here, Farzad. Get some primary care docs in the room.
3 years ago, he said, well, I'm going to think about changing the way I deliver care. He was thinking about getting an electronic health record. But these systems have been around for 20 years. This information infrastructure has been around for a long time, but in 2009, only about 20% of docs used them because they were expected to bear the cost of these systems, but other people benefited. And it's hard making this transition. So as part of the American Recovery and Reinvestment Act, this is the reinvestment part of the Reinvestment Act, right? Congress said, we're going to help defray the cost of that. There's going to be incentive payments for doctors and hospitals, for Medicaid and Medicare providers, if they take that step. So he, Dr. Ho, is going to earn, when California opens their Medicaid program later this year, he's going to earn $22,000 for having invested in the information infrastructure. Now, it was hard to do that for him. A lot of doctors don't go to med school to be IT project managers. So he had help from a nonprofit local organization that was funded by ARA funds to help him make that transition in a way, keep his records secure. Local solutions, local problems. There are 100,000 primary care providers across the country who have now signed up with one of these regional extension centers established. 100,000. What is that? That's 30% of all primary care providers in urban areas. That's 70%. 70% of rural primary care providers in small practices are working with one of these nonprofits to get to the meaningful use of electronic health records. Did you know that? That's an amazing groundswell of change. Are we seeing the results? This is a graph of the growth of providers who are using an electronic health record and electronically prescribing over the past 5 years. Did you know about this trend? You don't see healthcare change like that. Healthcare changes in generational time frames. But I think in the next 5 years, we're going to see a more profound change in how healthcare is delivered than we've seen in the past 50. But you may say, appropriately so what? So now you're using electronic health records to deliver the same kind of care you were delivering before. This is the difference. There's a landmark study in the New England Journal of Medicine last month. 27,000 patients with diabetes. And they asked the question, some of the patients were cared for in this community improvement project on paper. Some were cared for on electronic health records. Everybody, they tried to get everybody's improvement up. And they found that those diabetic patients who were taken care of, whose medical records were paper-based, got the right care, stuff that a third-year medical student knows that they should do. Check the blood sugar, give them a shot for pneumonia, check their blood pressure and lipids, do that eye exam, foot exam, the basic stuff. They got it the right care 7% of the time. 7% of the time. On the providers who were using electronic health records, they got the right care consistently. Not enough, 51% of the time, but they were improving faster. 51% of the time versus 7% of the time, and they were improving faster. Now you might say, that's just process. That's just maybe documentation of that process. How about the outcomes? On the outcomes, and outcomes like blood pressure control, sugar control, lipid control, not smoking, not being overweight. On those outcome measures, 16% of the time on the paper-based and 44% on the electronic health record. Okay, one thing electronic health records don't do, they don't make you skinny.
But Farzad, I want to ask you a very simple question. In a fee-for-service healthcare reimbursement environment,
Yep.
Are the physicians who are achieving the 44% outcomes versus those achieving a 16% outcomes, are they rewarded in any way, shape, or form for that action?
Not yet, Brother Chopra.
That's right. So we have right now an incredible array of technology that, as you see, is widely adopting or on path to be widely adopted in healthcare. And many of you presenting at TEDMED have demonstrated your own technologies. But it's one thing to have terrific capabilities. It's quite another to see those capabilities scale in the marketplace. The most important action, one of the most important actions, but certainly in this context, the most important action to deliver the care delivery change we see as critical for a value-based healthcare system was included in a provision of the Affordable Care Act. It empowers Medicare for the first time in its history to decouple judgments about how payments are done from the congressional or political process. Our fee-for-service system has been in place for many, many years, and I must assure you, there are folks every year walk on up to congressional offices in Capitol Hill and they say, here's the way we'd like to make some tinkering adjustments. And there's a political intervention about whether there'll be change. But the Affordable Care Act said payment reform absolutely must be in line with a vision for care delivery reform, because those doctors that achieve those quality outcomes deserve better reimbursement for having improved the health care for those patients. So Medicare Innovation Center was created under the Affordable Care Act and provided the following tools. They have the authority to pilot new models of reimbursement, to test and validate those models over 3 or 5 years, and this is the most important point. It is the actuary in HHS who will certify the results of those tests or validations such that if those payment models accrued value to the American Medicare or Medicaid systems, and the actuary certifies it as such, then the Secretary of HHS, with the stroke of a pen, has the authority to scale those payment models. A data-driven innovation pipeline management approach to ensuring that our healthcare payment system rewards the kind of outcomes that you're starting to see in practices all across the country. It is this latter provision, the change of payment, that is what's giving increased attention to the investor's thesis that the technologies you all have been working on for years and will continue to build now have the chance to achieve economic returns, improvements in healthcare outcomes, while creating the market conditions for those investments and those savings to be redeployed in support of this infrastructure.
Does this happen in the real world?
Farzad, this is happening today, live in the Medicare Innovation Center. We've already rolled out a number of these programs, a program on readmission rates to make sure that if hospitals basically struggle with the ability of patients that are going in for surgery, come back into the system shortly thereafter, that there is in fact a quality penalty if they don't get it done right the first time. That's really sharpening the mind. Ask hospitals today. This is one of the most important provisions of the payment system that they're paying a great deal of attention to. Second, we recently passed our final rule for the accountable care organizations. The rules of the road that would allow doctors and hospitals and other grouped combinations to engage in a discussion about managing a population of patients.
Can I tell a story about that?
Tell me, brother, what's going on in the real world from your point of view?
So I lied. When I said that Dr. Ho is doing fee-for-service, I lied. Because actually, he's part of an independent physician association. They're getting paid, actually, 160% of Medicaid. I heard today it's up to 180% now.
180% of Medicare?
Medicaid.
Of Medicaid.
Because under a managed care contract in the state of California, they're saving hospitalizations. By saving hospitalizations, they're getting paid more. So now this turns the construct of healthcare on its head. It changes it from being delivering healthcare the way we sell shoes, by which I mean you wait until someone walks in the door of your store and you say, "Can I help you?" to one in which we say, we have an obligation to the entire cohort of patients. The denominator, population health and population management. And that has profound implications. You can't do that with paper-based systems. Make a list of patients who have not walked in the door. Make a list of patients and find out who's most at risk. And that's what we need, not just payment for, not just technology for, but innovation.
So we've covered the fact that we're seeing a rise in the adoption of digital infrastructure in healthcare. We've talked about the new payment reform provisions that are part of the Affordable Care Act that will scale up these ideas that are value-based.
And Aneesh, not just Medicare.
Not just Medicare.
Medicaid and private health plans who have been waiting for this.
It's been a dream for health insurance companies all over the country who've been experimenting with payment reforms, but for the fact that Medicare and Medicaid haven't participated, they haven't had the kind of impact. We are no longer the barrier for those kinds of payment models to come into place, but these are only two of the elements of our innovation strategy. The third is that we are opening up this infrastructure so that others, you, could engage in support of the care delivery process. Dr. Ho has 180% of Medicaid reimbursement. Those additional dollars can be plowed back into third-party products and services that will allow him to achieve the objectives that Farzad just described. In fact, in Dr. Ho's practice, number one, it's important to note, in addition to his traditional electronic health record, he actually has a third-party Silicon Valley-esque startup that extends the value of that electronic medical record system by offering a Google search-like appliance to find information about his patients. That ability is because we are opening up the electronic health record systems and encouraging interoperability standards so those third-party products and services can interconnect and allow that doctor to achieve really a value-based care delivery infrastructure, team-based care and the like. But it's not just the EHRs that are opening up. We are also opening up government databases. Farzad, we have billions of dollars of your and my taxpayer dollars invested in healthcare measurement. We are tracking quality metrics in Medicare. We are tracking clinical advances in the NIH. We are tracking public health statistics at the Centers for Disease Control. And here, prior to this effort, those databases were available in reports to a few niche researchers who assigned agreements, and they were available in a model that really wasn't sparking the kind of innovations that we're seeing today, but now we are.
Let the data free.
We are opening up that information so that you, every one of you in this room, can access that information in machine-readable form, so that you can grab that data, combine it with the information in Dr. Ho's practice, and the combination of all of that is empowering the clinic to do more. But Farzad,
what
we
about
got
the patient, Aneesh?
Come on, brother, next page. Get the click. It's about this. We are increasingly empowering the American people. 300 million Americans. What's your role in the new care delivery system? Will you have access to information? We believe it is true. It has been a policy objective of ours. It's in our meaningful use framework. But we are not just talking about it, we are doing it. The VA, because the president challenged them in August of 2010, he said this fall, the VA will offer a little blue button, pictured above, that allows every members of our VA, our veterans, to download a personal copy of their health record, the PHR data, with a simple click of a button. Within 90 days, the startup that we launched, led by Dr. Peter Levin, put that into practice, and 1 year to the day, 500,000 Americans have downloaded their personal health care record. 500,000 people put that into their data in the VA, in the DOD, and in Medicare. And it's not just them. Secretary Sebelius convened a summit and said, all of these individuals, it's great that the government's leading by example, but it was the private sector, Aetna, United, Walgreens, and Jamie's in the house, patients like me. All of these
100 other data holders said it's not just the right of the patient to get their record.
Absolutely.
It's the right thing to do. And we're going to make it easy for patients and their loved ones to get access to the records, to take better care of themselves.
So bring us home, Farzad. We got infrastructure, we got rules of the road, we're opening up data for innovation. What's left?
Well, there's a lot left to be done, right? We've painted a picture about how there are these three trends: how care is delivered, how care is paid for, and how patients can engage in their own health. And those are important. Those are rocket fuels for this innovation to take place out there, right? Of all the different forms, and figuring it out. What's the payment model going to be? What's the care delivery model going to be? But it's going to take so much more, right? It's going to take a cultural change. It's going to take workforce changes. But perhaps the biggest barrier, this is tribute to our brother Todd Park, couldn't be here. He said, perhaps the biggest barrier to change in healthcare is healthcare's belief that it can change. That disbelief is a wall between us and the future healthcare we want and the patients deserve. That wall of disbelief is standing between us and that future, but it's paper thin. That wall of disbelief is paper thin. And there are points, holes that people have, sparks throughout that wall that you all represent. Little holes through that wall of disbelief that healthcare can change. And Todd said, it's time to put a freaking hole in that wall.
Yeah. Punch a hole in that wall,
Punch
people.
a hole
That's what we're going to do.
in that wall.
Let's do it
Punch
together.
a hole in that wall.
Thank you so
of
much for your
disbelief.
time.
Thank you.